Welcome back to the deep dive. If you are preparing for a career that touches on patient care, you know that anesthetic agents are a huge topic.
Oh, absolutely.
These are the drugs that literally control consciousness and pain. So today we're taking a deep dive into the core concepts, the safety protocols, and the crucial drug specifics you need to understand these powerful medications.
And really what we're talking about are anesthetics drugs designed to cause a controlled loss of sensation. The first thing you have to understand is that there are two totally different approaches here.
Okay.
You have general anesthetics, which are these profound CNS depressants. They cause a systemic loss of consciousness. And then you have local anesthetics, which are much more targeted. They're nerve blockers that act regionally, so you lose sensation in one area without, depressing the whole central nervous system.
That distinction is so important. Systemic versus regional. And when we talk about general anesthesia, we're not just trying to get the patient to fall asleep.
Not at all.
We're actually aiming for four very specific goals at the same time. What are those four pillars?
Right, so to do this safely, you have to achieve four states. First, analgesia, which is the total loss of pain perception. Then amnesia, so the patient has no memory of the procedure.
Crucial.
Very. Then, of course, unconsciousness, which is the complete loss of awareness. And finally, and this is the big one, the loss of reflexes, both the autonomic ones like heart rate changes and the skeletal muscle reflexes that would obviously interfere with the surgery.
And trying to get all four of those with a single drug sounds dangerous. Which leads us to this core strategy, balanced anesthesia. So why is using a cocktail of drugs safer?
It's all about minimizing toxicity. I mean, think about it. If you used one drug powerful enough to do all of that, the dose would be so high you'd almost certainly cause respiratory or cardiac arrest.
You'd push them into that deadly stage 4 we'll talk about.
Exactly. So with balanced anesthesia, we combine several drugs. Maybe an opioid for pain, a paralytic for muscle relaxation, a hypnotic for unconsciousness. We can use lower, much safer doses of each one to hit all our goals without causing those catastrophic side effects.
And that cocktail strategy, it actually starts way before the main anesthetic is even given, right? In the pre-op phase.
Oh yeah, we're setting the stage. For instance, we often use anticholinergics to dry up secretions, which prevents aspiration, and they also prevent the heart rate from dropping too low.
What else is in that pre-op mix?
We'll give sedative hypnotics for relaxation and to get that amnesia started. You'll also see things like antiemetics for post-op nausea, maybe some antihistamines, and definitely narcotics to help with pain control. All of this just reduces how much of the primary anesthetic we'll need.
Given how much is going on systemically, the patient assessment has to be incredibly thorough. What are some of the biggest risk factors you're looking for?
It's a full system review, no question.
Yeah.
We look at CNS factors, like an underlying neurological disease. That could mean they react unpredictably. Then there are cardiovascular factors.
Like heart disease or low blood pressure.
Precisely. For those patients, the risk of severe hypotension or dangerous arrhythmias under anesthesia is way higher. And of course, we have to look at respiratory factors. Things like COPD really complicate the ventilation you need during surgery.
And I imagine the organs that clear these drugs, the liver and kidneys, are just as important.
Absolutely. Impaired renal and hepatic function are massive red flags. The body uses the liver to metabolize these drugs and the kidneys to excrete them. If those aren't working, the drugs just accumulate.
Which means?
And it's prolonged anesthesia, maybe needing a ventilator for longer, or even toxic buildup that can cause more organ damage. The whole plan has to be adjusted for those risks.
Okay, let's walk through the actual experience for a patient. The source material maps this out with 4 predictable stages. What does that journey look like?
The stages just chart the depth of CNS depression. So stage 1 is the analgesia stage. The patient's still conscious, but they start to lose the sensation of pain. Then we move into stage 2.
Which is famously known as the excitement stage.
It is, and it's the danger period.
Why is it so feared? What's happening there?
This is where the sympathetic nervous system just discharges. The patient can get agitated, even combative. You see tachycardia, hypertension, fast breathing. It's a huge risk for injury or cardiac events. So the anesthetist's job is to use really rapid IV drugs to just blow past this stage.
Just get through it in seconds.
To get them safely into stage 3, which is surgical anesthesia, this is the goal. Muscles are relaxed, breathing is regular, vitals are stable, perfect for surgery.
And the stage we must avoid at all costs is stage 4.
That's stage 4. Medullary paralysis. It means you've gone too deep. The CNS is so depressed that the brain centers that control breathing and blood pressure just stop working. and that can lead to death very, very quickly.
It's so important to separate those 4 stages of depth from the 3 phases of administration. Can you break down those 3 phases for us?
Of course, the phases are about timing. Induction is from the start until you reach stage 3. That's where you use the fast IV agents. Maintenance is the whole period you're in stage 3 during the surgery itself, often using inhaled gases.
And recovery.
Recovery starts when you turn off the anesthetic and lasts until the patient is fully awake, moving, and communicating. And that whole time requires really close monitoring.
Let's jump into the drugs themselves, starting with those fast-acting IV agents for induction. The first class is the barbiturates.
Right, the barbiturate anesthetics. The prototype here is methohexital. It's an ultra-short-acting IV drug, so it's perfect for a rapid induction. Some people might remember thiopental, but that's largely off the market now because of its use in lethal injection protocols.
And methohexital has this really bizarre technical quirk.
It does. It's so strange. It cannot come into contact with silicone.
Wait, really? Silicone? Like in a syringe stopper?
Exactly. Rubber stoppers, some disposable syringes. If the drug touches it, the silicone can actually break down. So you have to use special silicone-free equipment to prepare and give it. It's a tiny detail with huge implications.
Wow. Okay, moving on to the second class, the nonbarbiturate anesthetics. The prototype here is midazolam.
Midazolam, yes. A potent benzodiazepine. It's fantastic because it has really powerful amnesiac and sedative effects. But this class has some other very interesting drugs.
Like propofol and ketamine, which are pretty different from each other.
Very different. Propofol is super popular for outpatient surgery because it clears the body so fast, less of a hangover effect. Ketamine, on the other hand, is fascinating. It creates this bizarre catatonic state. But its unique feature is that it increases blood pressure and heart rate.
So it's actually a stimulant in that sense.
Right, which makes it essential for patients who are hemodynamically unstable, like in a major trauma where you can't risk any more cardiac depression.
But with midazolam, there's a big respiratory risk, isn't there?
A huge one. It's a potent CNS suppressant, so it's associated with respiratory depression and even respiratory arrest. The bottom line is if you're giving midazolam, you must have life support and airway equipment right there, ready to go.
Okay, let's switch to the inhaled agents used for maintenance. First, the anesthetic gases, specifically nitrous oxide.
Nitrous oxide, yeah.
Yeah.
It's a great analgesic, very fast on, fast off. But because it moves so quickly, it has this unique side effect. It can accumulate in closed body spaces, your sinuses, your middle ear, your bowel, and cause a lot of pain.
And there's a key safety point with it.
Always. It's always given with oxygen. Always. This prevents post-operative hypoxia when the gas rushes out of the bloodstream back into the lungs.
And the last major class, the volatile liquids. Your prototype here is desflurane. These seem to be the workhorses for outpatient surgery.
They are. They're halogenated hydrocarbons. They allow for rapid onset and quick recovery.
Yeah.
But, and this is a big but, they come with a massive critical safety alert.
And that is?
All volatile liquids can trigger malignant hyperthermia. It's a rare inherited condition, but it's life-threatening. The body goes into this hypermetabolic state, temperature skyrockets, muscles get rigid. It's a true medical emergency.
That sounds terrifying. What's the immediate intervention?
The antidote, dantrolene, must be immediately available. On the cart, in the room, ready to push. This is why we have to ask every single patient about any personal or family history of bad reactions to anesthesia.
Which brings us right to the nursing safety checks. What else are we looking for in that pre-op assessment?
We need a baseline for everything. Neurological status, vitals, and definitely a baseline ECG to check for any underlying heart problems. And as we said, we have to know about any liver or kidney issues because that will completely change the drug choice and dosage.
During the procedure, when the patient is immobile, what are the key nursing interventions to prevent complications?
Besides having dantrolene and emergency gear on standby, the big risks are injury and skin breakdown. So you need side rails up, you need meticulous skin care, you need to be turning the patient regularly to prevent pressure ulcers.
Let's talk about specific age groups. How do children and older adults change the game for general anesthesia?
For children, it's all about the airway. They have a much higher risk of laryngospasm and bronchospasm. Plus, dosage calculation is incredibly complex. We usually stick to drugs with a proven pediatric safety record, like propofol and sevoflurane.
And for older patients?
Older adults are just more fragile across the board. They're more sensitive to the CNS effects, like confusion, and the cardiovascular risks are higher. Their skin is thinner, perfusion is decreased, so skin breakdown is a huge concern. And they often need prolonged monitoring because their liver and kidneys don't clear the drugs as efficiently.
You also mentioned a high-priority post-op intervention for them, promoting vigorous pulmonary toilet. Break that down for us.
It sounds funny, but it's critical. Because older adults are less mobile, they are at a very high risk for post-op pneumonia. So pulmonary toilet just means actively helping them clear their lungs, encouraging deep breathing, coughing, using those little incentive spirometers. It's all about preventing a deadly lung infection.
That's a fantastic overview of general anesthesia. Now let's pivot to local anesthesia. How do we keep these drugs contained to just one area?
It's all about the administration method. You can apply it topically as a cream. You can use infiltration, where you inject it right into the tissues you're about to suture. Or you could do a field block, where you inject it all around an area like a fence.
And then there are the nerve blocks for larger areas.
Exactly. A nerve block is when you inject along a nerve pathway. This includes things like epidurals and spinals. The goal for all of them is to maximize that local effect and stop it from getting into the rest of the body.
And how do they actually work? What's the mechanism?
They're powerful nerve blockers.
Yeah.
What they do is they block the nerve membrane's permeability to sodium ions. Nerves need that influx of sodium to fire an impulse. If you block the sodium, you block the impulse, the pain signal just stops cold.
And sensation doesn't just vanish all at once, does it? There's a specific order.
That's right, there's a sequence. First to go is your sense of temperature, then touch, then proprioception, which is your sense of where your body is in space, and last to go is skeletal muscle tone, and recovery happens in the exact reverse order.
Okay, this is really important. The two chemical classes of local anesthetics. Esters versus amides. Why does this matter so much?
It's a critical distinction because it's all about metabolism and toxicity risk. The first class, esters like benzocaine, are broken down right away in the plasma by enzymes. It's a very fast process.
So they're cleared quickly, less risk.
Exactly. The second class, the amides, and this includes our prototype lidocaine and bupivacaine, are metabolized much more slowly in the liver. Because of that slower breakdown, they carry a much greater risk of building up and causing systemic toxicity.
So if you do get systemic toxicity from an amide, what are the signs you're watching for?
It hits the CNS and the cardiovascular system. CNS effects start with restlessness and dizziness, but they can progress to seizures. CV effects are the most dangerous. You can see arrhythmias, a big drop in blood pressure, and even cardiac arrest.
Let's apply this to the AM critical thinking scenario. A 32-year-old athlete gets spinal bupivacaine. 2 hours later, he's agitated, his BP is 1-feel-468, heart rate is 88, and he can't feel his legs. Is this toxicity or something else?
Well, you have to think it through. Bupivacaine is a long-acting amide, so not feeling his legs 2 hours later, that's totally expected.
Okay.
Now, the elevated vitals, while they're high, they aren't showing that profound cardiac depression you'd expect with systemic toxicity. So the most likely cause here is actually intense anxiety and fear. For an athlete especially, losing control of your body like that is terrifying.
So the intervention is more about patient management than an antidote.
100%. The priority is reassurance, teaching him that this is normal and it will wear off. You also have to keep him lying completely flat to prevent a spinal headache. And, of course, meticulous skin care because he can't feel if a pressure spot is developing.
This has been a fantastic deep dive. To recap our key takeaways, balanced anesthesia is the strategy for achieving goals with minimal risk. In general anesthesia, stage 2 is the danger zone. And with local anesthetics, the amide types like lidocaine carry the highest risk for systemic toxicity.
And that leaves us with a thought to chew on. Given how narrow the margin is between anesthesia and paralysis, how might future innovations, maybe personalized, genetics-based dosing, help us prevent these adverse effects from happening in the first place, rather than just getting better at reversing them? It's a really interesting question for the future of pharmacology.
It really is. The need for precision just never stops. Thank you for joining us for this essential deep dive. We hope this shortcut helps you master this critical knowledge. We'll see you next time.